welcome everyone, and thank you for coming. This is very exciting. It's wonderful to be here for another symposium and hear some great talks. I have the privilege of introducing two speakers who are going to be speaking on the mental health for physicians and burnout, Dr. Zaki Ahmed and Dr. Sarah Newbery. So maybe what I'll do is I'm going to introduce them one by one and they'll come up and speak, and then I think we're going to have some time for questions. We'll hold them till the end, or maybe a discussion, and we'll invite them to come sit up here and we'll go from there. Does that sound okay? Awesome. All right, so I would like to introduce our first speaker, Dr. Zaki Ahmed. Dr. Ahmed is Chief of Staff at Humber River Health. He was previously Chief of Staff at Thunder Bay Regional Health Sciences Center. During his time at Thunder Bay, Dr. Ahmed established the educational program in the ICU and Medical Clinical Training Unit for their Internal Medicine Residency Program. Dr. Ahmed is an internist, a respirologist, and intensivist who has a special interest in quality improvement, health equity, and medical leadership. He has completed a master's certificate in physician leadership and a master's in health sciences and health administration. Dr. Ahmed is also an associate professor at the Northern Ontario School of Medicine. I welcome him to speak. Thank you.
Excellent. Well, thank you. Thank you very much for having me, and thank you very much for being here. So it was a pleasure to be invited to this event. I'm not nearly as qualified as my next colleague is. We share similar challenges, so it's just really good to be on stage today. So I was asked to talk about physician wellness, how it impacts research. So what I thought I'd start off with are some of the research studies that are out there right now, just to show you the impact of it and how important research is in this area. So starting off with the disclosure, I do not have any affiliation with financial or otherwise with any of the for-profit or non-profit organizations that would be considered a conflict of interest. As I said, we'll review some of the evidence-based data on the physician burnout across North America. We'll talk about opportunities for research where they are available for physician wellness. So we'll start off with a definition in terms of why is physician burnout different, and why is it so important? So as most people know, physician burnout is a psychological syndrome. It can be expressed as prolonged response due to chronic occupational stressors. But in the practice of medicine, it's a little bit different because it affects a wide variety of individuals, from medical students to physicians, practicing physicians. But the reach is actually beyond just those individuals. It impacts the healthcare industry, it impacts how we treat our patients, it impacts prevention strategies. It's really important to pay attention, pay heed to these areas because it is causing huge impacts on our healthcare of our society. Burnout's been referred to as a compilation of cynicism, depersonalization, low sense of accomplishment, and emotional exhaustion, inadequacy, detachment, and you can see how that would impact how we work every day and how we take care of our patients. So Medscape did a study looking at 13,000 physicians, so a very large participation rate amongst all 29 specialties. And what they start off with was the fact that the type of depression among physicians is slightly different. 24% of the physicians, so a quarter of the physicians that have depression amongst healthcare, 24% of them have clinical depression. So they have either severe depression, which is not caused by normal grief events. Then 64% of the participants that had depression had what was called a colloquial depression, which is just feeling down, blue, sad. This was the most important part of that part of the depression, that almost 10% of the participants felt that they had thought of suicides but had not committed suicide, and 1% of them had tried to commit suicide. So a fairly big impact. Obviously, women had more burnout than men, and a lot of that had to do with the fact that it's not just work, it's the home life that they have to manage and the other responsibilities that our women colleagues have. In terms of suicidality, women again had about the same as men in terms of gender, which is different than the general population, as you can see. And in terms of which physicians are most prone to being burnt out, as you can imagine, our emergency colleagues, critical care, obstetrics, infectious disease, and family medicine were the top 5. When it came to suicidal thoughts among some specialties, so if I go back, you'll see that pathology, dermatology, and surgery, orthopedics, they were lower down in the list. But when it comes to suicidal thoughts among specialties, they were the ones that had the highest rates of suicidal thoughts. So this was quite interesting that even though as a general population they have less people who are depressed, those who are depressed are much more significant. So what contributed to most of the burnout? Obviously, those of you who are in the room could relate. Too many bureaucratic tasks, so things like charting, paperwork, but also there was a big component of lack of respect from the administrators, employees, colleagues, and then the third one was too many hours at work, which a lot of us end up doing. Lack of control or autonomy was a big factor in here. And then insufficient compensation or salary was also a big thing, and this is important because it's one of the factors that can change. However, what we'll see is that that's not one of the bigger ones that needs to change. So do you feel that your personality type, so when they asked people if their personality types was contributing to them feeling burnt out, most of them felt that it didn't. And about a third of them felt that it was purely because of their personality that they were burnt out, which, you know, I'm not sure that that's necessarily true, but that's the way they felt. In terms of work settings, where are they practicing? So outpatient clinics, obviously much more paperwork, you're independent, you'd have less colleagues that are around. They felt that burnout was much bigger, and the amount of responsibilities that some of the docs take on being in outpatient clinics. Healthcare organization hospitals followed closely. So this is interesting. So in terms of how do physicians cope with burnout? So the first thing we end up doing is increasing exercise, thinking that that's going to help, all of it. So 48% did that. Some of them isolated themselves from others to help with burnout, which is not always successful. Talking with family members, close friends, sleep. But interestingly, when you go back to what caused it, how many of those things actually directly relate to trying to resolve the reasons for burnout? So the tools that we use does not correlate with the causes of our burnout. So that's important to understand. Although they're very good techniques to help with stress, they're not necessarily very good techniques to help with burnout. So are you more or less burnt out now than during the quarantine? So this study was done in 2022. So most of COVID, especially in the States, COVID-19 was over in March of 2020. When people were asked whether they feel more or less burnt out, interestingly, more people felt more burnt out after the pandemic. And a lot of those factors had been accumulating and building up. So why have you not sought help for burnout or depression? So this is very, very interesting and very interesting in terms of changing policies and things like that. One of the things that physicians said was that most of them felt that they could deal with this on their own. Physicians are always notorious for seeking help too late, and mental health is no different. They don't want to risk disclosure to the medical board. So this was a very interesting thing, and I know in Ontario that's changing. But when you're asked to declare any medical condition, again, people are afraid to put mental health down, and this is an important factor. And I know Dr. Foxcroft's going to talk about what her experience is. But this is a very important factor for your CPSO applications, for your hospital privilege application. So when you have to write down what are some of the things that, in terms of medical conditions, people feel that that's one of the reasons why they don't want to be diagnosed or get treatment. Also, insurance. So life insurance, health insurance, those of us who have that insurance individually rather than through the organizations, that becomes a big issue. When asked what would help reduce your burnout was more manageable work schedules, which is not surprising, but 38% felt that increased compensation because they were feeling financial stress. Greater respect from administrators, employees, staff. Obviously, a collegial environment is very, very important, and increased autonomy were the big ones, which is not surprising. So in Canada, so that was an American study. So in Canada, CMA conducted another study in 2021. So this is after the first and second waves that we were doing the study. So 4,000 physicians, they managed to get medical learners as well as practicing physicians. They did break that down into their analysis. They did was really good was that they compared it to non-physicians employed in Canada at the same time. So people are assumingly going through the same amount of stresses with COVID. So how is that impact the physicians more than non-physicians? So when they looked at mental health continuum short form, so in terms of flourishing mental health versus moderate versus languishing, and so all respondents, which is all physicians, had about a 47%, so about half of them were actually flourishing, but half of them were not. So this was very important. But also, 7% of the physicians felt that they were languishing in terms of their mental health, so not doing well at all. And what was different was that when they compared this to their cohort in 2017, was that the flourishing group actually decreased from 63% to 47%. The moderately mentally healthy actually increased, so they went from languishing to moderate and also into languishing. Burnout among physicians, in terms of high levels of burnout, high amounts of depersonalization, same thing, high amount of emotional exhaustion, high overall burnout, all increased from 2017 to 2021. Again, same results in Canada, where women physicians were more burnt out. But interestingly, the difference in 2017 versus now is something that I do want to pay heed to. So in 2017, there was a 29% to 33% difference, whereas in 2021, that increased from 43% in men to 59% in women. For many reasons, the impact of the pandemic was much higher on our women physician colleagues. In terms of who gets affected, so general practitioners, obviously much higher in Canada, whereas when you saw in the US thing, it was the emerge docs and the intensivists, whereas in Canada, it's the general practitioners. And we were sitting there at the back talking about some of the challenges, and I know that Dr. Newbery is going to talk more about the challenges that general practitioners have, but that is a big group that is affected by burnout. Not that anyone's precluded, but much higher. And interestingly, it's physicians. Initially, we would think that the physicians are much more burnt out later on in their practices, but that's not the case. Physicians are burning out much, much, much earlier in their practices. So 62% of them with less than 5 years of practice are now suggesting that they're burnt out. And it goes right through. So it doesn't matter how long. It's actually the people who have been practicing 21 to 30 years is actually the lower risk, but even that's 50%. And whether you're working urban, suburban, so obviously small town, rural, much higher. Isolated, remote, even higher than that. And this is, again, replicating what the US part said, was that lifetime ideation in the Canadian physicians is actually higher than the U.S. physician, and suicidal ideation is higher than the U.S. physicians as well. And rating of mental health, we just talked about before the pandemic. It's since then, 60% of them rated higher rates of or poorer rates of mental health than before the pandemic. So wellness supports offered at a workplace. So we have access to psychological support. They felt that they had access to psychological support. They had access to backup call. They had access to exercise facilities, access to primary care physicians. But 44% of them felt that they had access to nothing. So this is quite interesting that how we perceive what we have around is very important. And possible reasons physicians not seek, again, so no time. They're overworked. They don't have time to go seek out help, not just for mental health, but physical health as well. Believing situation is not severe enough, so we always think, oh, we're fine. And 47% of them felt that they were ashamed to seek help. And 30% of them felt worried about the confidentiality. But 20% of them, even in Canada, after changing a lot of those questions that come out, risk losing medical license or ability to practice, so which is a big concern. In terms of satisfaction, there's many physicians who feel that they're not satisfied, and only 15% of them feel very satisfied. So very concerning. Workload. So this is one that keeps coming up over and over again, where my control over the workload is very little. We talked about not giving new physicians a lot of workloads and stuff. We were just talking about that before this. And this is why, right? So workload burns people out. Work-life integration, very, very poor. So over half of our physicians are dissatisfied with their work-life integration. Time spent on EMR. 50% of the physicians feel that the time that they spent on EMRs is much higher than prior. In terms of time spent, general practitioners obviously spend a lot more time on the EMRs than specialists do. And so why does it all matter? Why are we all talking about all this, right? So 49% of the respondents considered reducing or modifying their clinical hours. So we know there's a huge shortage of physicians. We know we're going to have 3 million people in Ontario that won't have family physicians very shortly. And if that happens, and 49% of the respondents are considering reducing or modifying their clinical hours within the next 2 years, that's very concerning. But even what's even more concerning is the quiet quitting. We know that physicians who are dependent on the money that they make, can't afford to leave their practices, are now working burnt out in their environments. And in our field of work, performance matters. So what can we do? So at Humber, what we did was we created this framework over the last year in terms of how do we deal with physician wellness. So one of the things that we identified, and what you saw from this, is that everyone needs different supports, right? So to have a session where you're going to be just talking about your feelings, a lot of the physicians won't relate. Whereas if you have a session where you're just going to do yoga, a lot of physicians won't relate. You have a ski event, a lot of physicians won't relate. You have a financial talk, a lot of physicians won't relate. So you have to have a combination of everything. So what we did was we put in action items for all of those, in terms of all those areas had different things that we could do for those. I'm going to let Dr. Foxcroft talk about her study, but this is, so before I knew she was coming, I was going to talk about this, but she'll do a much better job. But there are things that people are doing. So in this one, it was a peer support program. However, there's still things that we need to do. We need to work on bureaucratic tasks. We need to work on how many hours people are working. We need to work on time spent on EMRs. So these are the things that we really need to work on. We need to work on how we build autonomy in decision making. How do we decrease paperwork and evaluate those tools? So these are really, really important things. We're putting things into place, but how do we evaluate the impact of that? And then political factors, right? So they are causing increased stress, out of our control. in terms of what's going on in the world today, but it's causing huge amounts of stress in our physicians. And environmental, social, we all know about that. There are areas for help, but they're more for individual help. We need to change the system that we're working in. So. Thank you.
Wish we had more time to get you. Could I invite you to come have a seat and we'll. Right. So our second presenter, Dr. Sarah Newbery, is the inaugural Associate Dean of Physician Workforce Strategy at Northern Ontario School of Medicine. In this role, she works with faculty, committees, and other partner organizations to support strategic initiatives to enhance the physician workforce in Northern Ontario. As a rural generalist family physician, over 25 years in the community of Marathon, Ontario, she has held leadership roles in primary care and the hospital sector. She is the past president of the Ontario College of Family Physicians and has been awarded by them as Family Practice of the Year. She has also been recognized as Teacher of the Year by NOSM, as Fellow of both the College of Family Physicians of Canada and the Society of Rural Physicians of Canada. Welcome.
Thanks so much, Andrea, for that lovely introduction. It really is a pleasure for me to be here and a delight to be able to reconnect with Zaki, who I haven't seen for a couple of years now, and really a pleasure to be here. I want to acknowledge that this is really my kind of venue. I'm a small town girl, and so small venues work well for me. There are probably more people working on this block today than live in my community. So being in Toronto is always a bit overwhelming for me, and I'm glad to be in an intimate space. So as Andrea mentioned, I'm a rural generalist family physician. I live and work in the community of Marathon. This is a picture from our clinic window, really meant to give you a sense of the integration of our healthcare system. It's the orange chopper landing behind our hospital. In terms of disclosures, I will share with you that I'm on the CMAJ advisory board and part of their governance council, and there is a focus on the theme of health human resources this year. I do receive an honorarium for the governance council work and for work with the OMA Human Resources Committee. I'm an employee of NOSM and have a couple of grants with NOAMA, one of which focuses on transition to practice for new grads. I have received support for this talk in terms of travel and accommodation, for which I am grateful to PSI. Thank you for that. I don't think that any of my work creates a bias for which I need to mitigate. The objectives that I'd like to touch on today include explaining the challenge of understanding the prevalence of burnout in the rural physician workforce specifically. I'd like to spend a bit of time describing the links between physician burnout, quality of care, and workforce retention, which I think Zaki has touched on well, and describe some of the unique features and the unique factors in our rural workforce, and in the north in particular, that can impact physician wellness and the challenge of accessing support. I do want to begin, though, by acknowledging what I feel is a great privilege of having been able to live and work in the traditional and unceded territory of the Ojibwe people of Bigtugong First Nation on the North Shore of Lake Superior. I want to say, though, in addition to that, that beyond a land acknowledgement, I think physician wellness and the way in which we support rural physicians who serve Indigenous communities is part of our call to reconciliation. I'll just take a moment and remind us that 23% of Canada's Indigenous population lives in Ontario. Ontario has 133 First Nations communities, 88 of which are in Northern Ontario, and 30 of which are in remote fly-in settings. The majority of healthcare to these 133 Indigenous communities, I should say, in Ontario, the majority of healthcare is provided in rural communities. Most of the hospital service that they access as their first point of entry into the healthcare system is in our rural settings. So if we want our physicians to be well and to be able to engage in delivering culturally safe, high-quality care for Indigenous populations, we need to be thinking about the wellness of our rural physician workforce and, in fact, all of our health workforce. I want to just spend a moment and remind you of the context of Northern Ontario. So, of course, this is a map of Northern Ontario. I've placed 6 stars along the bottom of the map. Those represent the 6 medical schools of Southern Ontario, including now Toronto Metropolitan University. You can drive for 7 hours and touch all 6 medical schools in Southern Ontario, starting with Schulich at Western in London and ending at the University of Ottawa in Ottawa. The two yellow stars in the top portion of the map represent the two campuses of NOSM University, Thunder Bay and Sudbury. They are 1,000 kilometers apart. You can't really do that drive in a good day. The yellow arrow represents my community of Marathon, which is 300 kilometers from Thunder Bay. And it is the largest community at a population of about 4,000, the largest community between Thunder Bay and Sault Ste. Marie. Northern Ontario has 5 urban settings: Thunder Bay, Sudbury, Sault Ste. Marie, Timmins, and North Bay. Only Sudbury is larger than Guelph, and the majority of people in Southern Ontario, I don't think, consider Guelph as a major urban setting. So the population, the setting for Northern Ontario is really very rural, and this comes to part of the challenge of defining rural. By international standards, all of Northern Ontario is considered rural. By Northern Ontario standards, we see 5 urban settings, and then the rest of the geography, the rest of the region is rural. All of the communities of Northern Ontario have a population of 10,000 or less when you get outside of those 5 urban centres. And the population of Northern Ontario altogether is less than the population of the city of Ottawa. So rural in Southern Ontario is not nearly as isolated as rural in Northern Ontario, and there's some helpful context, I think, for us to carry with us as we think about our physician workforce. In Canada, 18 to 22% of the population lives rurally, but only 8% of Canada's physician workforce does, and only 2% of Canada's specialist workforce lives and works in rural Canada. Care, of course, can be really challenging for 2 reasons. Well, for 3 reasons, really, but the first is the complexity of care in rural populations. They tend to be older, sicker, more complex, and often poorer than the populations in non-rural settings in Canada. There is a complexity of managing care across geography, and it has been my complete delight for 16 years to work with specialists like Zaki and Thunder Bay who understand that challenge. And there is a challenge of accessing specialist support broadly. Most of the specialists in the Thunder Bay area and in all of our northern communities are general specialists, so often we're working across distance from Marathon to Toronto or Marathon to London to access service for our patients. I'll highlight as well, I haven't seen updated HQO data, but the last time I looked, the life expectancy for people living in Northern Ontario was 2.5 to 2.9 years less than the rest of the province. And that largely represents a lower life expectancy for rural and remote and particularly Indigenous communities in Northern Ontario. Mental health and addictions is a profound challenge in Northern Ontario. 5 of the 7 public health units with the highest opioid death rates in the province are 5 of the 7 public health units of Northern Ontario. So there is a complexity of care delivery in the north that is impacted in addition by our lower health human resources. Zaki touched on the National Physician Health Survey, and I just want to highlight the elements that are rural specific. So the bars on the right-hand side of the graph represent rural and remote physicians who responded to the survey. The bars on the left are urban physicians, and you can see that on every metric, rural and remote physicians described their mental health as poorer. And I apologize for the font, it's a bit small, but they were more likely to have experienced fatigue at work, more likely to identify a lack of resources as contributing to their poor mental health, more likely by up to 15% to have had suicidal ideation, more likely to screen positive for depression, more likely to describe higher rates of burnout, less likely to have access in their workplace to the kinds of wellness supports that Zaki described, and less likely to access the supports that do exist. And I think that's largely because of confidentiality challenges in rural communities. I want to touch on sort of the two-edged sword of physician burnout and resilience for rural physicians. One is breadth of scope, but breadth of scope is actually protective. Physicians who have a broad scope, who work in clinic, work in hospital, cover some emerge shifts, generally, historically, have experienced higher degrees of resilience. It might be because they're not sitting in the office grinding away with the EMR all day. They actually have some protection until the burden of work across those settings becomes too great. And then that broad scope across settings actually becomes a challenge to mental health. Relationships with patients and community, likewise. Patients generally in rural communities love their physicians, and physicians love their patients and communities back. until they're not able to meet the needs of the community because there are too few of them. And then friction arises when patients can't get in to be seen in primary care, or the emergency department is closed when they need service. And that impacts the relationships that physicians have historically experienced as protective in rural communities. And then relationships with colleagues. Rural clinicians who work in rural settings tend to work well together. They tend to work in tight collegial groups. They are interdependent and they know it. But when the workload is spread, too much work across too few people, friction arises, and that challenge can become a source of stress and a source of burnout for physicians. I also want to talk just about 3 specific issues for rural clinicians. COVID-19 impacts moral injury, which is a little bit different than burnout, but is certainly linked. And then I just want to touch on grieving for physicians. Eva Perky, who's in Kingston, and Angelina Mandel, who's a medical student, did some work looking at specific rural challenges emerging from COVID-19 that impacted physician well-being. The increase in workload with new roles was a very specific issue for rural physicians. So I'll describe for you our community. We have 8 rural generalist family physicians. We run the primary care setting, we do all the inpatient work, we staff the emerge department 24/7, and when COVID-19 started, we also stood up and ran 5 days a week a COVID assessment center. The same 8 physicians, there was no new resource, and that was a very specific phenomenon, I think, for rural physicians who felt the need to keep that entire integrated local health system functioning. For many rural physicians, they described feeling like outbreaks were personal failures, that somehow they specifically had let the community down. And because rural physicians are often public and visible figures, they would encounter questions at the grocery store. The community knows who their physicians are, and it is hard to get away from that sense of failure. Social isolation and strained relationships. I think typically, as I mentioned, relationships can be very positive in rural communities, but when physicians are public figures and when there is a public narrative that might be anti-vax, anti-mask, and physicians are identified in all of the public spheres in the community as a physician, that can really strain relationships and erode well-being. Collegial isolation as protection and personal infection risk, I'll bundle this together. And I'll give you the example from our community. We completely separated from one another as a clinical group. We didn't meet in person, we didn't eat together, we didn't socialize, because if I got COVID and was in a situation where I passed it on to a colleague, that impacts our clinic, our emerge call roster, our ability to provide inpatient care. It impacts how we can staff the assessment center. So there was a very real understanding that my personal infection risk had huge implications for the way in which we could deliver care. And that social isolation, although we sometimes use it as a tool for protection, from a mental health standpoint, actually created significant challenges for rural physicians through COVID. I want to just touch on moral injury. This is a specific emerging conversation. I think the term moral injury is one many of us were introduced to during COVID, but we're hearing about it more and more from rural colleagues as we witness emerge department closures across the province. Those have actually been much more common in Southern Ontario than Northern Ontario. But physicians working in rural communities are being asked to make choices about whether their emerge department stays open or their primary care setting stays open. Again, it's the same medical staff of the primary care setting as the emerge department. And for physicians in rural settings, the idea that I might say, I'm too tired to do one more shift, and the emerge department would close as a result, and my neighbor might not be able to access care, that's a profound burden that rural physicians specifically are carrying right now. And we're hearing about this more and more as an issue that is leading physicians to choose to leave practice. And lastly, I just want to talk about grief. This is not a COVID-specific issue, but grief in communities for rural physicians can be a very specific issue. And I'll highlight a case from my own experience this summer to simply illustrate. There was an Indigenous woman in our community who was very tragically stabbed in July of this year. She came into our emerge department. We had a locum who was covering the shift. And she came in talking but collapsed very quickly. It was 2:30 in the morning. I was called in as his backup. And a CPR was in progress when I arrived. I went to the head of her bed and intubated her. We ran her resuscitation attempt for about 40 minutes and then pronounced her death. It was at that point that one of the nurses said, Charity, and actually called her by name. because I'd been at the head of her bed, she was upside down to me, and I didn't recognize her, but she is someone that I have known for 25 years. I delivered her babies, I know her aunties, I know her mom, I know her daughters. And the role for physicians of leading a debrief, leading a team that is grieving, and going out into the community in the subsequent days, and encountering family members and other people who are grieving, often leaves rural physicians without much support for their own burden of grief. And that this is not a common story, but it is a particular rural story for physicians, particularly when they have been in the community for a period of time and are embedded and woven into the life of that community. And it's an area that I think we can provide some particular attention. Andrea is standing, that's probably my cue that I need to wrap up, but I'll quickly go through these last couple of slides. Zaki has touched on this cycle from burnout to decline in team function, a decline in quality of care, and then poor outcomes, which contributes to worsening burnout. In rural communities, it's very hard for physicians to cut back. There's not another clinic they can shift to. They will remain publicly visible if they stay. So burnout often leads to attrition. Physicians simply leave the community, and when they leave, there's no backbone against which we can recruit. And that becomes a highly problematic cycle for rural communities. I want to just capture the slides that Zaki spoke to around what we tend to do to manage our burnout. I think it's really important that we understand that the opposite of burnout is not actually resilience. Resilience is just what lets you keep putting one foot in front of the other as you cope with your burnout. The opposite of burnout is actually joy in our work. And I think we have an opportunity to spend some time and some research effort to understand joy in work and to understand that in all of our contexts. So when I think about PSI and some research opportunities particular to rural communities and burnout, I want to just identify that the bandwidth for rural clinicians to participate in research or to lead research is almost zero. They are barely holding on with their clinical work. But I think there is appetite and there might be energy for good knowledge translation, good quality improvement efforts to support rural physicians and support retention, which I think would drive at some of the goals of PSI, which is to improve the health of Ontarians broadly. And I think there's an opportunity to think about how we might support rural and Northern Ontario through a different kind of research endeavor that may be more about implementation. And I hope that we might be able to explore that a little bit further later in the day. Thank you so much for the invitation to be here, and I look forward to questions.
Thank you so much. Thank you so much. Unfortunately, I don't think we're going to have a lot of time for questions, so I feel bad about that. Maybe we'll have time for, like, let's say one question before we go to break. I think we have one question over there.
So thanks so much. I think it's a really important question, and I think we do need to be identifying those models and spreading and scaling them. When I think about some of the issues in burnout that Zaki identified that are particular to EMR, I think that we need to find ways of looking at how we can use technology in new ways, perhaps AI and auto scribes that can help reduce some of the paperwork burden that physicians struggle with. When I think about the joy in work conversation, we know that joy in work comes from relationships with patients, relationships with colleagues, and a sense of both mastery and purpose. And if we can free time for physicians to have meaningful relationships with patients and colleagues and to continue to have a sense of mastery over their work that drives a sense of purpose, we can re-embed joy. And I think given the worldwide shortage of healthcare providers, I think we are going to have to look at ways that technology can free time without becoming the kind of burden that EMRs have become for clinicians now. That doesn't address your question specifically, but it's one of the things that I find myself thinking about, recognizing the profound nature of the workforce challenge that we have now.
Thank you, Sarah. So in addition to the mastery, it has to be a multi-pronged approach. So to be able to make sure that the autonomy is maintained amongst physicians, to be able to, for physicians to make it safe for them to reach out for help. That's another thing that I think some of our colleges are working on, some of our credentialing applications are working on. That's really big as well. There's some great programs coming out that Dr. Foxcroft is going to talk about in terms of some of the peer support. So we know that physicians will trust physicians. Unless you're in a small community, then confidentiality becomes an issue. So having those supports is really also important. So multi-pronged approach, it has to be.
Can we do another question? We're all fresh. It's the beginning of the day, right?
Yeah, absolutely. You're absolutely right. Not only is it just moral distress to see them go through that and to see the impacts of it, most of the physicians who are disruptive physicians are also the burnt out physicians. And so not that all burnout will cause disruption, but most people who are disruptive, most physicians who are disruptive are also burnt out. So dealing with them more in a coaching perspective rather than the disciplinary perspective becomes really important. For them to have a safe venue to have that discussion without being afraid of being judged for what they're able to do, if they're able to complete their work, if they're able to safely provide care. And so those are really important things. One of the things that we've done, so speaking of mentorship as well, at Humber is to develop a full mentorship program for new physicians. And with that, it actually comes with, helps them build support into the hospital. So these are the people that I can support, that can reach out to for support. So where in rural areas you only have a few physicians that you're friends with, most of the physicians that come into bigger centers, mine is much smaller than yours, especially in academic centers where mastery is paramount, and for you to be able to work as the best physician or the best researcher is really, really, really important. They're afraid to show that vulnerability.
Yeah, I agree with what Zaki has said, and I think the approach that I think you were hinting at, that sort of quiet coffee conversation as a way to start, is really important. I think one of the things that I feel a bit fearful about, and certainly is a reality in many small settings where clinicians are so dependent on one another to meet the need, is that opening the conversation to burnout might mean that that person actually says, yeah, you're right, I need to step back. And then who's going to pick up their call? Who's going to cover their patient? And I feel like the situation that we've arrived at in some clinical settings is a lack of willingness to actually enter into the conversation because of the implication for one's own workload. And I think that's a very difficult place and a very risky place for us to be as a healthcare system for the reasons that you've mentioned around performance and quality of care and disruption to the rest of the clinical group.
Thank you. All right, one last question.
Yeah, maybe the thing that I'll just comment on is to reiterate, I think, the important point that Zaki made at the close of his talk around, we tend to think of burnout as a personal failure, but it's a system failure for the reasons that you just mentioned. There are so many system pressures on physicians, and the answer and many of the solutions to how we re-enter a place of joy in our work, which it should be in medicine. It's such a privileged, wonderful profession. But so much of the work that needs to happen at the system level to make the workload manageable, to decrease that administrative burden and all of the things that you, I think, have rightly mentioned.
Wonderful. Thank you so much for speaking and for taking our questions. That was just wonderful. Thank you so much. And I think we have a break now.